This curve starts in 2013. Then when you start screening, you see an increase in incidence because of all the tumors you see. But after the couple of years, you saw a decline in the incidence. So that is actually entirely due to the picking up patients with polyps and removing the polyps. That also led to a decrease in mortality. We didn't expect this within the first 10 years. We thought it would take longer.
Perfect. We can keep with the program. So colon cancer reached almost 2 million in worldwide cases with a mortality that reached almost 1 million. To try to understand the prevention of this very preventable disease, we have a couple that is Regina Beets. Regina Beets is a professor of radiology in the Maastricht University Medical Center in the Netherlands, scientific director, European Institute for Biomedical Imaging Research, member of several associations, past president of European Society of Radiology, internationally recognized as expert in oncologic imaging, expert in abdominal cancer imaging and precision medicine, and leader in European cancer imaging research and AI-driven medical imaging. So after her talk, we learn about Dr. Geerard Beets, that is counselor, International Society of Oncology Prevention and Treatment, professor of surgical oncology, president of the European Society of Surgical Oncology, and chief of colorectal surgery at the Maastricht University Medical Center in Netherlands. Professor Regina, please.
Well, thank you very much for the kind introduction. So we decided to have a very short presentation, especially from my side as a radiologist. Colorectal cancer screening is, of course, not so much in our imaging world as is breast cancer and lung cancer screening. But I can show you some slides which may be useful for the introduction to Geerard's talk. So the European Council has updated the 2003 Council screening recommendation, and the updated version was adopted in December 2022, already shown by Isabel Rubio this morning. For the breast cancer, it had definitely been expanded in age period to the younger age, 45 years, plus the inclusion of MR imaging for very dense breasts. For colorectal, the FIT test being the triage to determine the follow-up via endoscopy or colonoscopy. And we know that the European Commission has an initiative on colorectal cancer to further offer evidence-based guidance on screening and care of colorectal cancer. What is the role of imaging? Well, it has been extremely investigated and also in the policy making, because we do have a tool which is called the CT colonography. Inserting gas, expanding the colon, we can reach sensitivities that are very high, equal to colonoscopy. But of course, everyone knows that a test which could immediately also offer a therapeutic intervention would be more desirable as a follow-up test after FIT. So the radiology world, in collaboration with the therapy world, has this recommendation. CT colonography is recommended following an incomplete colonoscopy when visualization of the entire colon cannot be achieved. CT colonography is acceptable alternative when colonoscopy is contraindicated or not feasible. and colonoscopy remains the preferred examination when therapeutic intervention is likely to be required, as it allows for biopsy and endoscopic removal of lesions. So that is the relative position of CT colonography nowadays. But we do use CT as a workhorse for TNM staging of colon cancer. And how good are we in there? Not very good. And I'll show you an example. For example, here you can see how the tumor is invading the abdominal wall. That's very easy for radiologists. But the problem comes with this kind of tumors. Is the tumor limited to the bowel wall? Is it just penetrating the bowel wall? Is it invading the visceral fascia? Those are all questions that we cannot answer very accurate because we simply do not see all these individual layers. So this is the reason why, and I think this is the most powerful thesis that I am now completing with one of my PhD students that look at the Netherlands Cancer Registry data. And we found that the agreement between CT and histology for TNN stage was not better than just tossing a coin. So I think this is the limitation of nowadays CT staging for colon cancer, unfortunately, and we need to find other methods, and maybe it is another biomarker, maybe it's AI, we don't know. We have to investigate that. Very small tumor volume detection can, of course, be feasible if we use targeted imaging, and with many new targets on the horizon, I think we do have a promise, although you may always ask yourself whether these will be cost-efficient methods. Well, the one that I already mentioned this morning, FAPI-PET, especially here, a study that looked into the nodes for gastrointestinal tumors, and you can see that the sensitivity and specificity are quite high as compared to FDG PET. So that is for now the imaging in colon cancer screening. Geerard, maybe for you now to continue.
Yeah, so cancer prevention and early detection on colorectal cancer. I have no disclosures except one. I was allowed to borrow slides from Professor Evelien Dekker, a gastroenterologist who was very much involved with rolling out the screening program in the Netherlands. So, of course, we know primary prevention works the best if it would be easy, but it's a hard thing, and it's more a society thing than a medical doctor thing. So what we as medical doctors are very good at is tertiary prevention, but that is only a small part. Surveillance of high risk groups. And why does it work very well? Because they're already patients, they're in our hands in our outpatient clinic. So it's the surveillance of the high risk groups and prophylactic surgery if required, but that only is a very small group of patients. So in between those two is, of course, the secondary prevention, which works best. So we have two things that make screening for colorectal cancer very attractive. That is the adenoma-carcinoma sequence. It's estimated to take 20 years or even longer. It's shorter in some patients, but it takes a long time. So you have your window to identify the precursor lesions. And then with all these precursor lesions, we can do a risk assessment. You see here some figures. If you have one small polyp, you can actually ignore it, but we can pick out patients who are at risk for developing cancer, and we can put them in a surveillance program. So secondary prevention is two things actually. It's early detection of cancers, but also, and it's probably more important, I would say it's almost for sure more important, removing the precursor lesions with the endoscope. So in the past, there have been randomized controlled trials with population screening, different methods, one-time sigmoidoscopy or these old fecal occult blood tests. And there's a potential to decrease the mortality between 10 and 30%. But organizing it on a population base is, of course, very different than running a randomized trial. So what's in the toolbox? People are often adding a questionnaire that is interesting to find the risk groups. So the workhorse is the fecal blood testing. So not the old one, but either the guaiac or the most recent one, the FIT test. You can do an endoscopy, which is more sensitive but more costly. And you have to make the balance here. Of course, colonoscopy is the highest sensitivity, but there is the risk of overdiagnosis, overtreatment, and cost. So generally, it's been said you start with fecal occult blood testing, followed by colonoscopy if you find something. So this is a global map. This is a recent review. It identified 45 countries where there are screening programs, and most of them start with an occult blood test. Some countries have the option, you can do the fecal occult blood test or the colonoscopy. What is arguably more important than the actual tool where you start with is the uptake or the coverage rate. So the top ones are countries from Europe where there's a lot of programs. So if you have an uptake of 5%, obviously that doesn't do a lot of good. So I will dedicate a couple of slides to the Netherlands here where I'm involved. So the uptake there is 70%, which is really, really good. So setting up the screening program took 10 years and a lot of money and capacity. So there were pilots being performed. We needed a high participation rate. What is the fit threshold? Because you can tweak it. And then there was lots of modeling. When is it becoming cost efficient? Do we have enough capacity? You have to set up the whole system with mailing out things with IT, and then you have to guarantee the quality, not just of the first test, but also the second and the third and the fourth. And most importantly, you need colonoscopy capacity. And that is where, in retrospect, I think we could have made a different choice, because in the Netherlands, we trained loads and loads of gastroenterologists extra. We're having a shortage again now, but I think we should have gone for technicians rather than gastroenterologists, helped with the AI tool. So 10 years of setting it up. Then it started gradually in 2014, 55 to 75. We are now lowering to 50. So that 2-yearly invitation and fit by mail. If it's positive, then you get a colonoscopy. And if something comes out, you either take out the polyp or you refer to the surgeon. So an important part of the quality assurance is the yearly monitoring, and this is 10 years after the introduction. The coverage rate is now 76. We're slightly worried it's going down. As always, women have higher uptake, and so men have a lower uptake, and people living alone have a lower uptake too. So we're looking at that. Then the fit positive rate was 4.5. It used to be higher when we started, and then the colonoscopy system was flooded, so it was dialed down a bit, the threshold. Then these people are invited for a colonoscopy. 85% show up for the colonoscopy, and there are 31% relevant lesions found. That is 4% tumors, and the rest are adenoma. If you take these figures down to the original group of over 2 million people, target group in 2024. This is what comes out. So 2.6% of all of the target population gets a colonoscopy. So 50,000 colonoscopies, it's a lot. And you find 1 in 1,000 cancers and maybe almost 7 in 1,000 lesions that are removed, and these patients go in a surveillance program. Now, so this is the input, what we have to do. So what comes out? So this curve starts in 2013. Then when you start screening, you see an increase in incidence because of all the tumors you see. The incidence was increasing overall because of the increasing age, but after the couple of years, you saw a decline in the incidence. So the little blip there is the epidemic, and it's further declining and it's sort of leveling off, whereas we would have expected a rise in incidence. So that is actually entirely due to the picking up patients with polyps and removing the polyps. That also led to a decrease in mortality. We didn't expect this within the first 10 years. We thought it would take longer. The decrease in mortality is also due to, and this is different from breast cancer screening, we see a marked stage reduction. Stage 1, half of the screen patients are stage 1, and the stage 3 and 4 is going down markedly. So we invested a lot of money, but it is paying off because we're giving less adjuvant chemotherapy, we're doing less liver resections, less HIPEC, less everything basically, except colonoscopies. And what we are seeing is many more early tumors. Half of them are stage 1. So we've learned to take out the big blocks of tumor and the surrounding lymph nodes, but is that still necessary in these smaller tumors? The gastroenterologist can take out lesions locally. We can take out lesions locally. It's now estimated that 40% of colorectal cancers in the Netherlands do not get major surgery. That is mostly due to the gastroenterologist, us doing local excisions and the watch and wait programs. So it changes the surgical work. So I'd like to conclude. Screening for colorectal cancer, the most efficient screening method, cost efficient and efficient, is first a FIT test and then a colonoscopy. It works both through early detection, but mainly through prevention by picking up polyps and removing them. It saves lives. And on the long term, it starts saving money, but you have to have a horizon of 10 to 20 years before it starts paying off. And the field of the surgeon is changing. So there's an increasing role for endoscopic removal of polyps, and we are doing far less extensive surgery. Thank you very much.
So now we can move to the other topics. Okay.